Well, thanks. It's really a privilege to be here and follow in the shoes of the past keynote speakers. One of the nice things is I've come to this meeting a couple times, and I'm a little bit peripheral to your acute unloading world, and I live mostly in the chronic heart failure world. But one of the things I like the best about this meeting is sort of the cross-pollination of ideas. And I sit here and hear these talks this morning. I just keep thinking of things that I could apply to the chronic heart failure world. And so here, my talk today is really about lessons from the chronic heart failure world that might be useful in the acute world that you live in, particularly, and we'll kind of wind our way toward the end to trial designs, that may be doable in humans for some of the amazing interventions that are happening. So we'll talk today about left ventricular remodeling, which has been a research interest of mine and my colleagues at Tufts, therapeutic effects and implications for trials, and lessons from the chronic heart failure world. So, the left ventricle is this amazing organ, right? I mean, it can enlarge itself and shrink itself. This is a wonderful review article by Joe Hill and Eric Olson from a few years ago in the New England Journal, showing that the heart can increase its size during hypertrophy up to 50% and atrophy itself during malnutrition, for instance, by 30%. So it just has this amazing ability to make itself larger, make itself smaller. And physiologically, this happens in real life in a couple of situations. Pregnancy, it's steady increase in blood volume, the heart gets larger and larger. Birth, reverse remodeling. And another normal scenario, high-end athletic training, the heart can hypertrophy, concentric or eccentric remodeling, which is physiologic and normal, and then with deconditioning, reverse remodeling back to normal. But our interest, and many people's interest, both here and all over the place, has been in the pathologic remodeling that happens after a myocardial infarction. And these are some images from a review article that my colleague Marv Konstam and I and some of our colleagues did a few years ago, showing what we now understand after large myocardial infarctions, particularly of the anterior wall or apex. There's a change in the architecture and the structure of the ventricle, a change in the size, a change in the shape, which has become known as post-MI left ventricular remodeling. So, in the 45 minutes of the talk today, what I'd like to do is walk through a brief historical perspective. What's the relation of remodeling to longer-term outcomes? What's the effect of therapeutics, drugs, and devices, again, from the chronic heart failure world? And can we think about this as a surrogate for outcomes in clinical trials? And we'll sort of visit the whole area of surrogates very critically. And then finally, how can we incorporate these concepts into trial endpoints? And I'll emphasize that I'm taking the macro view. I'm not examining myocyte biology as many of you do, or the interstitium. We're really looking at it from a bigger perspective. So first, some time machine journey back for a while. Much of this work, as Dan alluded to this morning, was done in the 1980s under the auspices of Dr. Braunwald, Mark and Jan Pfeffer. Rob Kloner did some of this back then. And this is a review article that was in the American Journal of Cardiology back in 1991, showing that after a myocardial infarction, there's initially infarct expansion, but then the remaining normal myocardium hypertrophies and dilates to call upon the Frank-Starling law to maintain stroke volume and hemodynamics as an adaptive response. But the problem is that this sort of continues on over time and becomes very maladaptive. And one of the first human studies was this, and it's always fun to look way back to these kind of studies. So this is 1986 in Circulation, Ray McKay and colleagues at Beth Israel Hospital in Boston. So this was 30 patients who had their first acute myocardial infarction treated with thrombolytic therapy. They had serial left ventriculograms baseline when they first came into the hospital, and then again 2 weeks later. And what they found, what you see, is that across the time points that left ventricular end diastolic volume and end systolic volume increased. So over 2 weeks after first MI, there was an increase in volumes. But really interestingly, pressures went down. So in other words, the ventricle was adapting to keep filling pressures low and maintain cardiac output. But there's a price to pay over the long term, and that is continuing left ventricular enlargement. The next phase, so this was described several times in the late 80s, early 90s, and then the next phase was, well, what's the relationship to the magnitude of how this happens early after myocardial infarction and long-term outcomes? And there was a number of studies showing this. And one of the really interesting ones was a secondary analysis of the SAVE trial, survival and ventricular enlargement, myocardial infarction, EF less than 40, patients randomized to captopril, 50 TID target, or to placebo, followed over a number of years. And Martin St. John Sutton at Penn had done an echocardiographic substudy of these patients. On the y-axis here is the change in left ventricular area, sort of a cross-sectional echocardiographic area, from time 0 at randomization to 1 year after the myocardial infarction. And then events were assessed over the subsequent time point, so from the landmark of the 1-year second echo. In the blue are patients who had no events. In the red are patients who had adverse events after that 1-year time point. And what you can see very clearly is that the change in the LV area over the first year was much larger in the patients who subsequently had events than compared to those who didn't. This was actually one of the first studies to look at a change over time in left ventricular area, really as a measure of remodeling, as opposed to just one time point at day 30 or so. And very interestingly, this relationship was independent of whether the patient was on placebo or on the ACE inhibitor. So in other words, if you happened to be on placebo and you didn't remodel, you actually did really well. If you were on captopril and you actually did remodel, you didn't do so well. But more people on captopril didn't remodel, and so overall there was a favorable effect. So this began to show that the change in left ventricular size, volume, architecture, shape in other studies relates to subsequent adverse cardiovascular outcomes. And so our interest over the years has been in the effect of drugs and devices on this process. So let's now spend the next few minutes talking about that. So Dan showed this wonderful slide earlier this morning from the work of Mark and Jan Pfeffer and Dr. Brownwald. So these were animals with either on your left a large myocardial infarction, on your right extensive, meaning much larger myocardial infarction, diastolic pressure volume curves. The little dots here are the normal area. And the effect of captopril in these animals with large or extensive myocardial infarction was a leftward or favorable shift in the diastolic pressure volume relationship. And a quote from this paper, thus captopril attenuated the left ventricular remodeling or dilation and deterioration in performance observed in rats with chronic myocardial infarction. So this was an important finding, very short term, and then they went on to do a long-term study. I mean, it kind of looks like curves from a randomized trial in humans, but of course this was in rats, where the rats were randomized to captopril or placebo, or water in this case, showing that there was improved survival in over a year after a large myocardial infarction by ACE inhibition. And then, of course, an amazing bench to bedside. They went on to do the SAVE trial that I mentioned before, survival and ventricular enlargement. Again, large myocardial infarction, EF less than 40, randomized to captopril or placebo. And then here, the y-axis is flipped to mortality instead of survival. But of course, the group randomized to captopril had about a 20% reduction in mortality, cardiovascular death, heart failure, hospitalization, sudden death. You know, whatever you measured was reduced by about 20%. So seen in rats and then seen in humans. And again, conceivably, the main underlying mechanism may have been the prevention of remodeling over time. So around that time, in the late 1980s, early 1990s, you know, we were very interested in this, and we were involved in the SOLVE trial, the studies of left ventricular dysfunction. So unlike SAVE, which was post-MI LV dysfunction, SOLVE, of course, was chronic heart failure, EF less than 35, and this was from the SOLVE treatment trial, symptomatic patients randomized to enalapril, 10 BID, or placebo, and followed over time. So we ran the radionuclide sub-study of SOLVE, where several centers in SOLVE did radionuclide ventriculograms at multiple time points on the y-axis at baseline, 4 months, 12 months, 33 months. And then WD is withdrawal, and I'll tell you about that in a second. So we stopped the drug or placebo and then repeated the study 2 or 3 weeks later. The y-axis is end diastolic volume index from radionuclide ventriculograms. And my colleague Marv Konstam was the driver of this. I was the fellow drawing little regions of interest on all of these things, so that's what you do. If you look at the green curve, which is the placebo group, so they started out here, and 4 months, 12 months, 33 months, This is left ventricular remodeling in chronic heart failure. These are patients who are just on digoxin and diuretics plus placebo. They were not on ACE inhibitors, and this is what the natural history of remodeling is in chronic heart failure. So the effect of the ACE inhibitor enalapril, an early reduction in volumes that was maintained across the course of almost 3 years after randomization. And then in our studies, we like to build in this withdrawal study because every time you give a drug like an ACE inhibitor, there is a little bit of an acute unloading effect, and we're interested in what's the chronic long-term effect on the underlying architecture in the absence of the acute dose-to-dose effect. And so what you see is that after you withdraw it for about 2 weeks, there's an increase in volumes, but you end up about back where you started, at the baseline. And so really, this difference here at the withdrawal, this is the net prevention of the remodeling effect from the ACE inhibitor on left ventricular structure and architecture over 3 years of follow-up in chronic heart failure. And so, we published this, and around the same time, the main results of the SOLVE treatment trial were published in the New England Journal, showing that enalapril reduced mortality in these patients. So between the SOLVE results and the SAVE results, we started to see a bit of a pattern here. In the SOLVE treatment trial with enalapril, the effect on LV volumes was to lower them or decreased, and mortality was decreased. There was another part of the SOLVE trial called the prevention trial, which was asymptomatic patients with EF less than 35 randomized to enalapril or placebo, trying to prevent the onset of heart failure. Volumes over 3 years were mildly decreased, and mortality was mildly decreased. I don't have time to show you all those data. And then, of course, there's the SAVE trial with captopril. Volumes were decreased. Dan showed those data this morning, and also in the St. John Sutton study, and mortality was decreased. So you start to get the flavor, like maybe these things are related. But if it is, it should be something that translates into other drugs as well. So let's look at other drugs. So this is a trial called Capricorn, which was a trial with carvedilol, a beta blocker. So post-MI, LV dysfunction, on relatively contemporary therapy. This was published in 2003. So these patients had primary perfusion. They were on statins, aspirin, ACE inhibitors. The idea behind Capricorn, by the way, was that the beta blocker post-MI trials all took place 10 million years ago, and do they really apply to contemporary therapy? And so the Capricorn trial randomized these patients to carvedilol or placebo. But for our purposes today, let's look in your upper left, the effect on end diastolic volume over 6 months. In the placebo group, there was an increase in left ventricular volume, blunted in the carvedilol group. EF went up in the carvedilol group, didn't change very much in the placebo. End systolic volume, same pattern. The placebo group increased over 6 months, and in the carvedilol group decreased. So favorable effects on remodeling post-MI in LV dysfunction with a beta blocker, carvedilol in this case, on top of other therapies. And what was the effect in the overall trial? There was a 23% reduction in mortality in the carvedilol group compared to placebo over about 2 years of follow-up. So now we can add to our table, and there were many other studies where carvedilol in chronic heart failure increased EF, volumes went down, mortality was improved. So beta blockers, or carvedilol in this case, decreased volume and decreased mortality. So now some evidence that it seems to cross drug categories. Let's keep going and build our table here. So here's a trial that may have been under the radar for some of you, a drug called ibopamine, so a dopaminergic receptor agonist studied mostly in Europe. And this paper is written by Hubert Poulour and Michel Rousseau from Belgium. And they had worked with us in the SOLVE trial, and they asked us, would we, in our core lab, sort of analyze the nuclear studies, the MUGA scans for volumes. We said, sure, we'd love to help you. And so they had this kind of phase 2-like trial of ibopamine. And here's on your left the placebo group, on the right the ibopamine group, end diastolic volume and end systolic index. Orange is baseline, red is follow-up. And what you see here is that over about 2 to 3 months, the volumes increased in the ibopamine group compared to placebo. These were chronic heart failure patients. Now, everything else that they measured, exercise time, New York Heart Class, everything else got better So they were really unhappy with us about these results, honestly. And if you go to this paper, it's like a sentence at the end of the results. They really were, they said, oh, we must have done something wrong. And, maybe we did, you never know. So then ibopamine went on to a large survival trial called PRIME-2, and here you go. It increased mortality by 26%. So here's a drug that made people feel better in the short term, improved exercise tolerance, but kind of killed people in a large randomized trial. Not that it's bad when trials don't go well, but at least for our purposes, we were kind of okay with this because it fit into our conception of the world that, here's a drug that increased volumes and increased mortality. So now, the story seems to be building a bit. So let's look at one more. So this is etanercept, so Anti-Tnf Therapy. This is a paper from Doug Mann and Beacom Boskurt. Again, phase 2 type of trial. Let's look at the short-term effect of a drug on remodeling parameters. So this was a pretty small study, advanced heart failure patients, 3 months of biweekly subcutaneous injections of etanercept. These were echoes done blinded. It was, very rigorously done. And what you see here is a dose effect. So placebo group over the few months of therapy, EF went down a little, didn't change much in the low dose, improved in the high dose. End systolic volume, dose effect. End diastolic volume, dose effect. So this looks like a great drug. So large randomized trial, of course, comes next, and that was called Renewal, and no effect over time. So etanercept 2 times or 3 times a week, over a couple of years of follow-up, completely neutral outcome trial, despite the incredible remodeling results, which was a dose effect. And again, you usually don't see that. It's usually one dose. So that sort of threw us for a little bit of a loop because, it didn't quite fit perfectly. But, why should it, right? I mean, biology is really complicated, as we have seen this morning. So, why would we ever think that one marker should always give you the signal that you want? And so we began to think, this is not really a surrogate, and surrogates almost never actually work. But these things are more like probability signals. If you see a signal, it tells you the likelihood that you'll see something in a phase 3 trial. It does not always work. And so that gets us into the surrogate discussion for outcomes in clinical trials. And so, let's step back and sort of look at it from the perspective of regulatory approval. And again, this is about the chronic heart failure world. So regulatory approval for a new heart failure molecular entity or a device requires a favorable effect on outcomes or some favorable effect on symptoms with sufficient outcome data to exclude some threshold of adverse outcome. Improving symptoms is fine as long as there's a certain safety margin there. And, as you well know, in the chronic heart failure world, we're now up to a point where trial sizes, like with the Paradigm trial of Entresto, 8,000 patients, to really see that effect because event rates are pretty low. So, it's hard to develop agents like that, and it's really hard for devices. And so, of course, because of this, there's a lot of interest in identifying some markers in phase 2 studies that can predict phase 3 success or failure with some reasonable degree of certainty. You'd rather do a trial of 100, 200 patients and get some red light signal or green light signal. That's where the whole interest in surrogates and biomarkers and imaging markers comes from, to try and get some kind of green light, red light signal with just hundreds instead of thousands of patients. If you're interested in surrogates, the classic 2 papers to read are by Prentice in Statistics in Medicine in 1989 and by Tom Fleming and Dave Demetz in the Annals of Internal Medicine. I would say the Annals of Internal Medicine one is a little easier to read than the Statistics in Medicine one. So when is a marker a strong surrogate? Well, here's what they say. So the surrogate marker has to be in the causal pathway between the intervention and the outcome. All of the intervention effects pass through the marker in that causal pathway. And then finally, and this is where many get hung up, a change in the marker is reflected in the change in the outcome. Now, every time you pick up a journal, there's some marker that's prognostic for something. Thousands, every journal, every month, every week. Almost none of those is the change correlated with the change in the outcome. Change in the marker, change in outcome. That's what makes a real surrogate. It's the changes in the marker reflect changes in the clinical outcome. And so, okay, we're going to pause for a quiz. Let's see how you do here. So you are the new chief medical officer of Megacore Drug Company. The CEO, on your first day, charges you with selecting 2 drugs to move into phase 3 from their really broad portfolio of completed phase 2 studies. So you have to choose 2 of the following 5. Ready? Number 1, a drug for heart failure with reduced EF that doubles natriuretic peptide levels, so bad, compared to placebo in 2 phase 2 trials. Number 2, a neurohormonal modulator for HFrEF that raises ejection fraction 4 points compared to placebo over 20 weeks. Number 3, a drug for HFrEF in which 2 of 3 phase 2 trials show a reduction in natriuretic peptide levels. We think that's good, maybe. A drug for heart failure and preserved EF that has no effect on echocardiographic left atrial volume at 24 weeks. Or finally, an IV vasodilator for acute heart failure that lowers natriuretic peptides over 2 days infusion and shows lower mortality at 6 months. Okay, so I will ask for a show of hands. You can choose 2. How many of you would choose number 1? No one. How many of you would choose number 2? 1 person. Wow. How many of you would choose number 3? Okay, about half the audience. How many would you choose number 4? How many of you would choose number 5? Almost everybody. Okay, let's see if you're going to hang on to your job. All right. Number 1 is called metoprolol succinate, or Toprol XL. Reduces mortality by 33%. In 2 phase 2 trials, natriuretic peptides at 4 to 6 months doubled. No one knows that, except me, I guess. Why did that happen at a time when volumes were smaller and EF went up? I don't know. I called John Burnett and said, why does that happen? And he said, oh, it's probably something to do with clearance. Yeah, we wrote a paper about that 15 years ago. So I don't know, but there you go. A neurohormonal modulator, that was 1 person over to my left. That's called moxonidine. That's a central sympatholytic that increased ejection fraction, 60% increase in mortality in a phase 3 trial. So, no. 2 phase 2 trials showed a reduction in natriuretic peptide. That's the direct renin inhibitor aliskiren that had a completely neutral effect in large phase 3 trials. So that was a no-go. Ryan, here's the one you wanted. So this is spironolactone in the Americas. Get rid of the Russian Georgia people where they weren't even taking it. But in the Americas, there was a favorable effect. We could argue about the statistics if you want. So a favorable effect on outcome, but no effect on left atrial volume, which we would think might be a good surrogate in HFpEF, right? And the last one is called Sur Relaxin. This one many of you picked, so you're all fired from your CMO job. So Novartis, went to the FDA and they said, oh, 6-month mortality, save lives, et cetera. The FDA said no, tertiary endpoint, do a whole trial, and they did, and there was no effect at all. So it's, the surrogate thing really is a hard one. Biomarkers that are prognostic are not necessarily good surrogate measures. And we know this, right? In cardiology, PVCs are prognostic. You suppress PVCs, or some of you younger folks may not remember, in a trial called CAST, increased mortality. We think low HDL is associated with increased cardiovascular disease in 10,000 epidemiologic studies, which of course it is, but you raise HDL in a certain way with torcetrapib or other drugs, you increase mortality. So prognostic markers don't necessarily work. And the real problem is even outcomes don't predict outcomes. And so some of you may remember, this is a drug called vesnarenone, an oral inotrope. Okay, now we wince when we hear that, but back then we didn't. And so this was a phase 2 trial, and you can see from the numbers here, about 400 or 500 patients. And there was an improvement in mortality and morbidity up on top, and mortality on the bottom. This is published in New England Journal. And Otsuka, I think, at the time, right? This is Otsuka, I think. So went to the FDA and said, what? Art Feldman, right. and said, please approve this drug. It saves lives. And they said, well, that was a phase 2 study, wasn't pre-specified. And oh, by the way, if you're looking carefully, in 400 or so patients, 10, 15%, that's only 50-ish deaths. So, we tend to look at p-values and say, wow, but, there are these other things like power and, event rates. And so the FDA said, no, please go do a real phase 3 trial where that's the hypothesis and powered appropriately, and that was called VEST. And the opposite happened. So here, mortality was improved. Here, mortality was worsened in a dose-related effect. So even outcomes don't predict outcomes. That's how hard this area is of phase 2 trials. So the message is don't ever become a chief medical officer. It's really hard. Seth. Sorry, Seth's doing great, though. Okay, so, and the problem with surrogates is that, of course, we know this, biology is complicated. So the progression of symptoms and death in chronic heart failure, you can have another acute MI, you can have arrhythmias, you can have non-compliance and progress. You can have neurohormonal-driven remodeling, which is where we aim most of our targets. You can have worsening kidney function. You can have mitral regurgitation. A surrogate isn't going to capture all of this. And, we look at all of these different things. But can it capture some of it? That really is the question we're interested in. So it's unlikely that any individual marker will represent this heterogeneity of pathways that drive the progression of a disease like chronic heart failure. But maybe the magnitude of correlation between effects on something like remodeling and effects on outcome, maybe that can give you a probability signal. So stop thinking of biomarkers as surrogates and start thinking of them as probability signals of success. And there are situations in which this works. I mean, ideally, how would you figure this out? You have large phase 3 type trials where you have mortality outcomes or cardiovascular death outcomes, and you have a marker that's measured in everybody in the placebo group and the drug group. And we, in fact, have this in lipid studies. This is a really nice paper from a couple years ago in JAMA from Mike Silverman, who was a fellow at the Brigham when he did this. And the circles are primary prevention trials, the squares are secondary prevention trials. This, on the x-axis, is the placebo-corrected difference in LDL levels. The y-axis is just a measure of the vascular event outcomes. And there's a general correlation between the magnitude of effect on LDL and the magnitude of effect on the outcomes. It's not perfect, but there is a relation. This is as good as it gets in the surrogate world. But imaging biomarkers, particularly remodeling where you have to do echoes or MRI, that's hardly ever done in everybody in large phase 3 trials. It's just prohibitively expensive, with some exceptions, like the VALHEF trial. And so, we were trying to figure out, how do you figure this out? And so what we did is we hypothesized that drug or device effects on remodeling correlate in some way, weakly, strongly, with drug or device effects on outcomes. So first, step 1 was figure out the outcomes. And so assess drug or device effects on outcomes on mortality, let's say, from the entirety of the literature. And you know how sometimes, interns or residents come to you and say, oh, can I get involved in a research project? And most of the, you give them something and half of them never come back. So, one of our residents way back when, this guy, Dan Kramer, came to me and I was, thinking about this and I said, okay, go find every study that's ever been done in chronic heart failure, where there's a mortality trial, and then go find every study that's ever been done, where there's a remodeling trial. And he said, oh, okay. And then I thought he would never show up, but he showed back up like 6 months later, and he had done it. It was amazing. And so here's the list. This is, as a paper a few years ago, it's now larger. So this is 25 interventions with 70,000 patients with long-term follow-up. This is mortality outcomes in heart failure, either favorable, all the drugs we use, bisoprolol, candesartan, CRT, ACE inhibitors, carvedilol, neutral effects and outcomes in chronic heart failure, DIG, bucindolol, amlodipine, and unfavorable effects, flosequinone, there's ibopamine we talked about, milrinone, there's moxonidine we talked about. So we knew we had an entire list, and then we said, okay, for all of these drugs, Dan, go find everything that's ever been written on remodeling of those therapies. So there was almost 90 trials in 20,000 patients. And then let's correlate the effects. And this is what you get. So on the x-axis is the difference in ejection fraction in this case, because that's where there's the most data. Placebo-corrected change in ejection fraction. The y-axis is odds ratio for death. And every data point here is not a patient, it's a trial. Okay, so for instance, everything here at 0.67 is carvedilol, for instance. And blue are the trials with the favorable effects on outcomes, black is the neutral effect on outcomes, and red, here's like moxonidine and all of that. And so, what you see is a general relationship between a drug or device effect on ejection fraction and the effect on mortality. And there's a little less information on end diastolic volume in these papers, but again, a general relationship. The bigger the difference, the bigger the favorable change in end diastolic volume over a few months, drug or device therapy in chronic heart failure, the more likely you'll be in this quadrant where the odds ratio is less than 1. We had a very talented statistician working with us who created these curves, and on the y-axis is the probability of either a favorable, neutral, or adverse outcome in these phase 3 trials, and the x-axis is the mean change in end diastolic volume. And so the idea here is that if you, in theory, have a new therapy that reduces end diastolic volume by, let's say, 10-ish milliliters compared to placebo, there's about a 70-ish% chance there will be a favorable effect in phase 3. There's about a 25-30% chance there'll be a neutral effect. And there's almost no chance, actually, that there'll be an unfavorable effect, at least based on the literature that's out there. And so our thinking is that no biomarker is likely to capture the complicated mechanisms that drive heart failure progression, but for phase 2 studies, the effect on remodeling in this case can potentially provide a probability signal of success in phase 3. So let's take those concepts and then kind of weave toward the end here. And how can we incorporate this into trial endpoints? And for us, this is really what we wanted. We wanted to figure out a way where we could make trials easier to do, not need 8,000 patients. So here's the problem in heart failure trials. So back 2003, the Valiant trial, post-MI, LV dysfunction. This was about ARBs versus ACE inhibitors. And here's Paradigm with Entresto, a little more contemporary. And if you look at the one-year event rates, back in the early 2000s, 20% of people in these trials had an event. More recently, 10 to 15% of patients in chronic heart failure trials have an event. So that means 80 to 90% of the patients in these trials with hundreds of sites are not contributing to the primary endpoint. Can we be more efficient and do this in a different way? So this involves different ways of thinking about trials. And the three things I'd like to cover in the last few minutes are hierarchical composites. One's called the Finkelstein-Schonfeld, the other is the win ratio. They're very related. Adaptive designs and expedited access pathway. And all of these things are now happening in the chronic heart failure world. Devices are a little out in front of drugs, but none of these are foreign. I mean, this method was used in the Partner TAVR trial to analyze the primary endpoint. It was used in the Pfizer tafamidis trial in amyloidosis recently to create the positive primary endpoint. So these are out there being used. So let's talk first about the composites. And I'll use the Finkelstein-Schonfeld as the example. The win ratio is similar in some ways. So it's a hierarchical comparison of events or timing in pairs of patients. The composite accounts for clinical priority. Death is more important than heart failure hospitalization. It allows for the potential incorporation of longitudinal measures like change in end diastolic volume or change in ejection fraction. It enables every single patient in the trial to contribute to the endpoint, not just 10 or 15%. And it potentially can enable incorporation of recurrent events, which in heart failure trials happens. So let me just illustrate this for you, since I'm not a statistician and this helped me understand it. So let's say you're doing a new cell therapy trial, and you have 100 patients in your cell therapy group, and you have 100 patients in your placebo injection group. And so you do your cell therapy or your sham injection, you follow everyone for some period of time, and then you pick out a patient from group A and you pick out a patient from group B, so you compare them, this pair of patients. And you first ask, did they die? Did either one of them die? So if B22 died but A didn't die, A wins that pair. But, in all of these trials, death is very uncommon. So most likely, neither will die in this. And so you then go on to the next level, which in this case might be heart failure hospitalization. And in this case, if B was hospitalized and A was not during that follow-up, then A wins that comparison. Or if B was hospitalized twice and A was hospitalized once, A wins. Or if B was hospitalized at 3 months and A was hospitalized at 8 months, A wins that comparison as well. So timing can be put in there as well. But again, in at least chronic heart failure trials, many times neither will be hospitalized. So that's where you can then go on and work in something like end diastolic volume or ejection fraction. And if A went up 5 mLs and B went up 25 mLs, A wins that comparison. And so then you compare every patient to every patient. You have 100 in A, 100 in B, so you have 10,000 comparisons. And by the statistical magic of what they do, you come out with a winner overall and a p-value, and one group wins compared to the other group. And the delta, the change, has to have a plausible relation to outcomes. So in chronic heart failure, we think that's just remodeling measures. In acute trials, that may be infarct size, actually. And so the other analytic approach that I think is now being incorporated a lot in heart failure trials and may be very useful in trials of acute unloading is the idea of adaptive designs. And here is something very recent, September 2018, from the FDA. This is their guidance on adaptive designs. It's actually quite readable. I'll show you one sentence. For the purpose of this guidance, an adaptive design is defined as a clinical trial design that allows for prospectively planned modifications to one or more aspects based on accumulating data from the trial. Now, we all have done trials, and when you're designing a phase 3 trial, you never have enough information. You always wish you had more. This is a way to use the accumulating information to inform what you're doing next. And basically, and thanks to Ajar, wherever you are somewhere out there, Kochar from Duke, who pointed this one out to me. This is called the DAWN trial, thrombectomy in acute stroke, something I don't think about too much. But this trial used an adaptive design to find what Scott Berry has published called the Goldilocks effect. So it's not too small, it's not too big, it's just the right size. So here, the adaptive trial design allowed for a sample size ranging from a minimum of 150 to a maximum of 500. They actually stopped at about 200 or something because they had the answer. So there's not a fixed sample size. It's adaptive over time. And you continue to enroll until the probability reaches some threshold of success, then you stop enrolling and continue to follow. And for trials of devices, like Impella in acute myocardial infarction, they're really expensive. It's nice to find the right number of patients to get your answer instead of too many or too few. And then finally, the expedited access pathway, I'll just mention, is another sort of FDA initiative. This is a little bit older, a couple of years ago. So the idea here is if you get enough early signal, you can potentially get an early approval while the patients continue to be followed. And it's hoped that the EAP, or Expedited Access Pathway program, will help patients have more timely access to these medical devices. This was mostly focused on devices, but the concepts, can be used really in anything. And we are incorporating these into chronic heart failure trials as we speak. So to me, I almost can't understand in this day and age why you would not do a trial like this, a large trial, either in the heart failure world or in your world. But let's use heart failure as an example. So you randomize to the drug or device or placebo control. You have your early, expedited access pathway early time points, let's say 9 months after randomization, and you assess, again, this is chronic heart failure symptoms or 6-minute walk, quality of life, some marker, ejection fraction, end diastolic volume, that has a plausible relation to outcomes, or a Finkelstein-Schoenfelder win ratio composite. And there are ways to incorporate Bayesian probability at that point of what the outcome is going to be, which we're weaving into one device trial, and potentially get an expedited early approval. The patients continue to be followed for the late time point for the true outcomes, cardiovascular death, heart failure, hospitalization. But throughout this, you use these adaptive design principles to kind of continually update the sample size while controlling the type 1 error to not need too many patients or not need too few patients. And this, you could take this design and say, let's do this for large acute myocardial infarctions with some support device and just adapt it accordingly. But it allows you to just really study the minimum number of patients to get to a really rigorous outcome. And all of this sort of presupposes that you've thought a lot about what your surrogate is going to be and how well that has been validated in literature. So we've sort of woven our way from the mid-1980s, the first look by Mark and Jan Pfeffer and Gene Brownwald, et cetera, on this, to the relation to long-term outcomes, effective drugs and devices, surrogates, and then finally how we can use all these principles to make our clinical trials faster and very rigorous, while assuring safety for our patients. And so, I'd conclude just by saying left ventricular remodeling is a stereotypical response to injury or loading. The remodeling process is associated with adverse outcomes and is a fundamental driver of heart failure progression. The remodeling response to a therapy provides a probability signal of that therapy's effect on outcomes, and this concept can be leveraged into novel trial designs to enhance the likelihood of an outcome response with smaller sample sizes. Thank you very much for the invitation. It was really a pleasure.
That was absolutely phenomenal. So, the hallmark of a great talk is always making sure that we educate, and the Q&A session, of course, I think humbled us all to the world of surrogates. One of the questions that I had as the audience thinks about their own questions, is as it relates to the DTU STEMI. And so obviously we can't talk about the results or anything, but I think one of the things that we struggle with is, the link, as you nicely showed, between imaging and clinical outcomes, and the various imaging modalities and the potential pitfalls just around the imaging itself. So can you speak a little bit to, when you select those surrogates and you show EDV, for example, are there other studies that have started to, really parse down on what are the best imaging modalities for specific studies? Infarct size is a great example.
Yeah. Well, I think that's clear. I mean, we know that cardiac MR is probably best for all of those things, for volumes, for ejection fraction, for infarct size. And, there's more precision, you get a more rigorous answer with smaller standard deviations than you would for echo, let's say, in chronic heart failure, or for SPECT imaging for infarct size. And so, as much as possible, in contemporary practice, that really is what should be done. Having said that, I'll say that virtually everything I showed about those EF data, in those meta-analyses we did, was with echo or nuclear studies. And MR was a very, very small part because it just wasn't around, through when many of those things were done. But if I was designing a trial now, I think you would do MR unless you couldn't.
Great. Comments, questions from the group? Umang?
Or the subsequent pivotal trials. So you may not have the right clinical significance.
Right, and that's a really, really good question. In the device trial in chronic heart failure that we're doing now, the design paper isn't out there yet, so I can't give you too much detail, but amazingly, the FDA really just, for that, it's one piece of a hierarchy, just a statistically significant difference. Now, as you know, if you have 1 million patients, you can have a half a point. So it probably won't be that. But I think that in general, you would look at reproducibility and you want something outside the reproducibility. For infarct size, let's say, in the paper that Greg Stone did 2 years or so ago from this large meta-analysis we did, it looked like a 5% difference in infarct size made a detectable difference in outcomes. So I think you can use some of these meta-analyses to answer that question. In general, for EF, it's probably about five absolute points.
So first of all, thank you very much for a phenomenal talk. I'm going to be practical a little bit. And there is no doubt that with the improving outcome in general, you have to do different techniques statistically in order to reach statistical significance. And you will do that with adaptive design, side by side, with WIN technique in order to get there. And you will get the FDA approved. But then what you face is the third layer, is actually the insurance companies. And they will say, you know what, wonderful, this is statistical significant, and probably it's good for the patient, but you didn't prove to me mortality. And it's going to the first phase. And a classical example right now is CardioMEMS, that need to go back and do again a full study on the one outcome that only based on that will get reimbursement. So I don't know if this needs to be in line with the third party that is going to pay for all those great medication.
It's a really, really important point. And so in the chronic heart failure world, you're right about CardioMEMS. The device studies that we're doing now with autonomic regulation devices, you know, the expedited approval is just one piece. I mean, the patients continue to be followed, and one component of the early endpoint is a greater than X% Bayesian probability at that point that the outcome, the longer-term outcome will be favorable. But everyone continues to be followed, and patients continue to be enrolled until that X exceeds 90%. You know, then enrollment stops and everyone's followed. So, you know, if put it in the terms of CardioMEMS, as you said, you know, so you get it out there, and you know, people are doing CardioMEMS, right, and they're getting reimbursed. It probably could be a lot bigger if we actually knew there was some mortality signal, and so you just continue on. And you know, if I'm the sponsor, well, I'm selling some of them, and I'm doing the larger trial, and hopefully I'll sell more of them. So I'm not saying to approve drugs or devices purely on the basis of markers. Like I don't, you know, there has to be woven in there, you know, enough outcomes to make it plausible. But you know, again, in the heart failure world, you know, that same argument comes up. Well, if something gets approved on the basis of symptoms, you know, quality of life, 6-minute walk, and a neutral outcome, well, if I'm a patient, big thumbs up. But you know, sponsors are worried about payers. But we'll see, because you know, as I'm sure you know, in the HFpEF world, that's where everything is shifting. So we'll find out if people will pay for it or not.
Jim, thank you very much. You made the point that it was a change in biomarker over time, and that correlation that really is what we need to be looking at and shooting for. Are there ways to do that in a shorter time period? So, for example, looking at ventricular reserve. So I measure pre and post intervention, whether that's exercise or inotropic challenge or something, to allow for a shorter follow-up period?
Well, there could be, but you know, you'd have to sort of do the same kind of analysis showing that, you know, drug placebo effect on X over 2 weeks correlates in some way with the drug placebo effect on outcomes. So, you know, it's a bit of a tall order. You know, we did it based on 30 years of literature. So when you have something new, it's kind of hard to do that.
Great. Final question, Michael.
Yeah, thank you very much. The question I'm asking is the relative value of the surrogate you are choosing with respect to other factors. Let's say, for example, you take end-diastolic volume for heart failure trial. Do you think that over time there has been an evolution of the respective weight, for example, with respect to age, gender, diabetes, so that the surrogate you are choosing is no longer as important in the determinant, as a determinant of outcome that now as a population has changed?
I'm sure there is. It is very hard to just tease that out. You know, our look at this is from a very 30,000-foot view, and you know, because these are trial level, not patient level meta-analyses, it's very hard, other than in a gross way. You know, in all those trials, we know what % were male and female. So, you know, we actually haven't done that kind of analysis, and you know, I suppose we could give it a try, but. So I don't think there's an answer to that question. We just know that, you know, I guess another way to look at it is when we've looked in individual trials that we've been involved in. Well, first of all, I guess for outcomes in the heart failure, chronic heart failure world, as far as I know, there's almost never been a gender interaction, you know, with drugs. You know, there's a little bit in ICDs, but not in meta-analyses or one of the CRT trials. And we've never seen it in the remodeling studies we've done, that there's been a big difference in men versus women, as an example. We haven't looked at age, but age affects the response of the LV to exercise and things like that. So I'm sure somewhere there is detectable signals, but we don't know how to find them.
Great, we're going to stop there. Thank you, Jim. That was a phenomenal talk.